Hi guys, and welcome to this makeup virtual care camp of care camp number 4. And we're going to talk a little bit about manual sheath pulls, we're going to talk about TR bands, and we will also talk about some resources for all of that. I'm not going to go over all of the objectives with you. We're going to kind of breeze through this just a little bit. But we're going to talk about the different types of access, brief review of the anatomy, manual compression techniques, those kinds of things. So manual compression, it is the gold standard for which hemostasis and is achieved. Fem stops are nice, but they are not the go-to. Preferably, you should always use manual compression. Your fem stop should only be used as an adjunct when you have successfully exhausted all manual compression efforts. Typical sites for your arterial access, common femoral is used, the radial is used, the brachial can be used. They can even do axillary. There was a patient in the ICU not too long ago who had to have like a fistula open or something like that, but they went in the axillary artery to open that fistula up. They can do popliteal. Typically, I can't tell you that I've ever seen that. The most common site if they're doing a cardiac cath is usually the common femoral. And then the radial. So when we look at the femoral artery and where it is, if you can find your inguinal ligament, you can find your femoral artery, and it runs from the anterior edge of your iliac crest to across the rim to the symphysis pubis. So you can see this is the catheter entrance where they have it circled, and it leads them up to the heart. They can look at the left side of the heart, they can look at the right side of the heart, or they can even do electrophysiology studies. This is just another picture to demonstrate the anatomy of your femoral artery. You can see that ligament sits just over it. So in the femoral region, from medial to lateral, remember vein, artery, nerve. And you can also see by looking at this picture, the artery sits very closely to that nerve, and how you can easily make your patient have a vasovagal maneuver, or not maneuver, but vasovagal reaction, sorry. So manual compression supplies. Before you go in the room, you should gather your supplies. The first thing I like to do, the policy suggests that you have 2 nurses in the room. I know that you guys deal in the real world and that probably will not happen, so what I usually used to do is I would have a battle buddy or somebody I would tell, hey, cover me, I am gonna go pull a sheath, and if you hear me scream, you should come running. I would also have my just-in-case supplies, which would include amphoatropine. I wouldn't open it, but an amphoatropine, a liter of saline with tubing, unless it was already hanging. And the other reason you tell somebody else you're going in, if you're holding pressure and your patient becomes bradycardic and hypotensive, are you going to quit holding pressure to give that atropine? I mean, if you can give the atropine one-handed, mad props to you, but I'm not that skilled. So, other thing, sterile gloves. Yes, you are supposed to use sterile gloves. Sterile 4x4s, and I always have a gaggle of 4x4s just in case I get a bleeder. we don't use lidocaine. You and the patient both should have access to the call light. Some sort of bandage, you can use the BioPatch and Tegaderm. And if you are vertically challenged, you may want a chair or step stool. Even if you're not vertically challenged, you may get tired after a while. Our beds are very high, so have a chair or a step stool. Technique, you're going to assess the distal pulse prior to compression. You're going to put on your sterile gloves. You're going to locate the pulse at the access site. Take 2 fingers, apply it above the puncture site, and 1 finger on top of the site prior to your sheath removal. And you're going to allow for a quick spurt of blood and apply firm pressure. So before you do any of this, you should locate the pulse and tape a flathead Doppler on top of the foot, so you know exactly by listening if you've occluded the pulse, and you can sit there and time it more accurately. The other thing you can do, if you cannot find the flathead Doppler, would be put a pulse ox on the toe, and when you occlude the pulse, you will see a flat line. Another thing to note is, so we see the skin insertion site, but the actual insertion of the catheter into the artery is located above the skin site, probably about two fingers or so, but the actual site that we need to hold pressure on is where it enters, where the catheter enters the artery. So the quick spurt of blood that you allow when you pull it out allows for any clots to get dislodged and go out the patient instead of traveling elsewhere. The other thing you should do is pull back 5 to 10 cc's in your lines. That will also prevent clots from dislodging. During the manual hold, you're going to monitor the blood pressure every 5 minutes, so make sure that you change your automatic blood pressure cuff to every 5 minutes. You're going to hold pressure firmly enough for 1 to 2 minutes to occlude the pulse, and then you will release slowly and very slowly. If the patient has had only a diagnostic cath, then you hold for 20 minutes. If they've had a diagnostic cath with 2B3A inhibitors, then you're going to hold for 30. If they've had an interventional cath, whether it had a 2B3A inhibitor or not, you're going to hold for 30 minutes. So basically, what I can't remember 20 this, 30 this, just 30. You're going to hold pressure for 30 minutes at least. Your compression should be forceful enough that you prevent bleeding, oozing, and hematoma formation. You're going to allow formation of the clot at the site where it enters, where the catheter entered the artery. Just some food for thought. If you have a patient who's got a size 6 French sheath, the hole in the artery is actually an 8 French. So the hole in the artery is 2 sizes bigger than the sheath. They don't recommend peaking. They say no peaking. Make sure that you apply pressure over the whole time, the whole 30 minutes. If you're peaking so much that it's every couple of minutes, then you're peaking more than you're holding pressure. If you just have to see it, I would wait till you're 20 minutes into it, because if you're bleeding, you will see your 4x4s get soaked with gauze, or your 4x4s get soaked with blood, and you will know it. So there is no reason for you to peak. Manual Compression technique looks a little bit like this. You're going to place 2 fingers over the site where the catheter entered the artery and 1 finger over where it entered the skin. When your hemostasis is achieved, you should monitor the patient for another 5 to 10 minutes. Just sit there, talk with them, put your line in the trash, whatever it is you've got to do. You're going to assess their distal pulses, look at their feet. Is it cool? Is it purple? What does it look like? Dress the wound with a sterile bandage per our protocol, which you can use a Tegaderm and a 4x4. You can use a Tegaderm and a biopatch. Just make sure that it is sterile. Just like when you pull it, you should be wearing sterile gloves. Make sure that you tell the patient, though, that just because the line is out, that they must keep that limb immobile. If you have a patient that is struggling to remember this, neomobilizers are wonderful devices that will allow you to take better care of your patient, and for your patient not to be able to like jack that leg up. There are some compression challenges. We'll talk about those. Your patient may have had an antegrade puncture. So instead of holding above where it enters the skin, you're actually going to hold distal to the skin incision because that's where it enters the artery. You'll compress it just like you would the other way. You're just going to be lower than you would for a retrograde puncture. Patients who come from the cath lab typically receive a gaggle of Plavix, a gaggle of 2B3A, heparin, all this stuff that makes them bleed. So you want to make sure that you hold the full 30 minutes, and you may even need to hold longer, just depending. The other thing is that these patients are at a higher risk of rebleeding. Hypertension, if you have a patient whose blood pressure is above, say, 140, then that is going to go against everything that you're trying to accomplish. The artery system, of course, as you know, is a high pressured system. So the higher the pressure, and it may make you have to hold pressure all that much longer. My suggestion for this is, 1, make sure that your patient's blood pressure is below 140 before you pull. 2, if you have pain medicine, which generally you do not, give them some morphine or fentanyl or something to help make them relax enough where you can pull that catheter, because as the time goes on, they may start to get anxious, their back might start hurting if they're a chronic backer. If you don't have pain medicine on your order set, sometimes you do, sometimes you don't, then I would get pain medicine and give it prophylactically before you even start to pull. Obese patients definitely pose a challenge for sheath pulls because it is difficult to palpate their pulse. They may have had multiple puncture attempts in the cath lab or wherever they came from, and they also have come with multiple comorbidities, whether it be diabetes, hypertension, COPD, all of these things. And it also is difficult to compress their arteries because their arteries tend to be deeper down. Something you can do, though, if somebody's got a large abdomen that is getting in your way more than it's helping, you can tape it back before you pull the sheath. That way it stays out of your way and you're able to get to the artery and hold that pressure that you need to. Complications, they can have a vagal response, they can form a hematoma, pseudoaneurysm, AV fistulas, they can have a retroperitoneal bleed, vessel occlusion, embolization, or even infection. We'll talk a little bit about those. Vagal response is usually caused by stimulation of the vagus nerve, and because of the large artery, the compression, and the pain, your patient may have one of these responses. So the patients I've had generally have said, oh, is it hot in here? Can you turn an air on or something? I am super hot. So, then you look up on the monitor, their heart rate drops, then their blood pressure drops. They may complain of being nauseated. Atropine usually can help correct this response. Sometimes they'll say with vagal reactions, stop the stimulus, but if the stimulus is you holding pressure, maybe you should let up just a little bit, especially if you're past the occluding time. Hematomas, it's a blood-filled mass around the puncture site. If the patient has an expanding hematoma, then it can result in a significant blood loss. It can be treated either by compression or they may have to have surgery. And it's important to note that a sign of a growing hematoma is a sign of active bleeding, and it needs to be monitored fairly closely. This is what an axillary hematoma looks like. Not very pretty. And sometimes, this is another picture of a hematoma on this x-ray, and sometimes with a hematoma they may need a transfusion, and it may take as long as 2 to 3 weeks for the hematoma to resolve. Things the person with a hematoma may complain of: sight, burning, or pain. They may say they have difficulty moving their hip or leg. They can have tachycardia, and they can have hypotension from the blood loss. Usually it's a red-purple skin discoloration. Things you can do as the nurse: if it's growing, then hold manual pressure. Notify your doctor if it appears to be severe or if it's getting worse or actively growing. Check their vital signs every 15 to 30 minutes until the hematoma is stable, and then every 2 to 4 hours. The other thing you can do is take a permanent marker and outline the hematoma, and measure the thigh girth every hour and make sure that size is not changing. A pseudoaneurysm, it's an encapsulated hematoma that's in communication with the artery. It's a pulsatile mass, may have a bruit. It can be detected by ultrasound, and if it's greater than 3 centimeters, it may be treated by ultrasound compression or surgery. I actually had a patient with one of these one time, and 2 hours into it, we got an ultrasound. They said there was a pseudoaneurysm. I think we ended up holding pressure something crazy like 4 hours, and I am not over-exaggerating. It was actually 4 hours. So the next day, after holding all this pressure, finally the patient had, quit bleeding, all that. They got another ultrasound, and they found no evidence of pseudoaneurysm. The pseudoaneurysm had actually resolved. So here's a couple of pictures of a pseudoaneurysm. Again, it is a hematoma that is encapsulated, and it is communicating with the artery. And just another picture of your pseudoaneurysm. It's often associated with a puncture below your common femoral bifurcation, or even initial inadequate hemostasis. So it's extremely important that we hold pressure, and that we hold pressure appropriately. What they may complain of: they may have, again, groin pain or burning. They may have back pain. They may have swelling at their groin site. They may have ecchymosis. They can have a pulsatile mass or even a bruit. What you will do is, again, assess your vital signs, your groin site, your pulses, check your thigh girth, and get some CBC and coags. An AV fistula, it's an abnormal connection between your artery and vein. It can be diagnosed by continuous murmur or bruit, usually detected by ultrasound or Doppler. They can do ultrasound compression, they can do fibrinogen injection or surgery for treatment. They can also, it's usually caused because of an inadvertent puncture to the vein while accessing an artery. Or even if you've got a patient who has both the venous and the arterial sheaths, if you pull both of those at the same time, this can be a result. So you can see this is your artery and your vein, and they have actually kind of sort of formed one here, but that is what the AV fistula looks like. And just another shot, as you can see, the artery and the vein have become best buddies, and now they are one. So what does it look like? What will your patients report? Swelling at the groin. They may have leg pain. They can have tachycardia, decreased blood pressure. They may have some shunting going on. What needs to be done here is, again, frequently monitoring the patient, checking for decreased pedal pulses, and checking for Breweys. Retroperitoneal bleed, it's a escape of blood into the peritoneum. Patients usually complain of flank pain, in the back. It's important, though, if you have a patient who is one of these chronic back painers, that we differentiate, is this your normal pain, or is this something new? And the easiest way, of course, to find out if it's something new or their typical pain is to ask the patient, or if they're unable to tell you that and they're unsure, then maybe reposition them and alleviate some pressure off that area and see if that helps. Usually the hematocrit drops, and then you'll see a blood pressure drop. Retroperitoneal bleed is a life-threatening situation. And right over here, you can see why it's a life-threatening situation. This is a retroperitoneal bleed. This is a portion of bowel that should be where that bleed is, but all of that blood that has accumulated in that patient's belly has pushed it over. They can have bowel infarction or bowel ischemia as a result of this retroperitoneal bleed. They can also get a vessel occlusion. The limb becomes cool, blue, diminished or absent pulses, usually treated with heparin, lytic agents, or even a thrombectomy where they'll go in and take the clot out. Patients may report pain or numbness and tingling, paresthesia, and it happens more frequently in your patients with diabetes or PVD. They can have also embolization. It's where emboli showers from plaque or a foreign body. Again, they'll have blue toe or some ischemia, treated with heparin, thrombolytics, or surgery. Infection in the groin is usually caused due to a breach of sterile technique. They'll have fevers, chills, drainage, and it can start as soon as 1 hour post-catheterization. Usually diagnosed with blood and site cultures, treated with oral or IV antibiotics. Mechanical compression devices, there are several of them out there. There's the FemStop that most people are pretty familiar with, and then there's what we call a C-clamp or a compressor. Off to the right is a picture of the FemStop, and off to the left is the compressor. The FemStop works with a manometer like you have on your blood pressure cuff, so you air it up 20 millimeters of mercury above the patient's systolic blood pressure, and then you'll slowly over time decrease it once hemostasis is achieved. Actually, if you look in the policy, arterial sheath removal, it goes step by step and tells you, when the pressure on the FemStop is supposed to be what. Now you can imagine, though, with these FemStops, that if your patient is a patient of size, that these FemStops do not work the best for them. The other thing, like the letters say on there, you have to have an MD order. It is to be used for an adjunct therapy only, not as a substitution for manual pressure. So this says these devices replace hand pressure in manual compression. However, you know, here at St. Mary's we follow the best evidence-based practices, so you should attempt to hold manual pressure first. These devices have to be monitored during their use. They can have complications just like a manual pull, such as vessel occlusion, hematoma formation, or uncontrolled bleeding. There are what we call closure devices. They have suture-based or collagen-based. They're designed to achieve immediate hemostasis. It allows them to ambulate earlier and to be discharged earlier. Here's a couple of pictures. There's the angioseal, which is like a little plug, vasoseal, little collagen plug. Perclosed is suture-based. And then you have your star close, which is like a little plug of nickel that they'll put in the artery to achieve the hemostasis. But typically these patients can walk in as little as an hour after having that closure device put in. And again, your closure devices, they can be suture based and allow for earlier ambulation and discharge. Alright, so in summary, manual compression is the gold standard for achieving hemostasis. Make sure that you are using a sterile technique, and you need to apply enough pressure to prevent bleeding, oozing, and hematoma formation. So now we will look at the policy, and it's again called the arterial sheath removal policy, and it is a very excellent policy. It will walk you step through step how to do it. If you see definitions, there's closure devices, femstop, TR band. It tells you what you need to get in prep to have in the room. This page has what the procedure is. So follow general pre-procedure guidelines, document baseline blood pressure, heart rate, pedal, brachial, radial pulses, document an Allen's test if it's a radial sheath, use ACT protocol, pull the sheath if the ACT is less than 180. And heparin should be stopped prior to pulling the sheath. If you get one of these patients and heparin is still infusing, then you should call the physician and get orders to stop it, or at least clarify it and see if he still wants you to pull the sheath. Prior to removing it, another good point is make sure your patient voids. There's nothing quite like you sitting there holding tons and tons of pressure and your patient has to go to the bathroom. Make sure you treat your hypertension. Talk to your patient, discuss with them what you're going to do, what they can expect to feel, and those kinds of things. It says have 2 nurses readily available, so just tell the second nurse, cover me, I'm going in. So we've already talked about a lot of this. Let's go to... Alright. Sorry. So C here is femstop for femoral access sites. Again, you need to obtain an order to use. The femstop is not to be used as an alternative, but it does do a great job of telling you what you need to do. So look at 3 there. After opening the femstop, start by activating the pump. Pull the red battery release in the direction of the arrow. When it is shown on the dial, the pump is activating. So, but it says the target inflation pressure should be 10 to 20 millimeters of mercury above the systolic pressure and do not exceed 200. You're going to check your pulses, and then when the dome is in the correct place, increase the pressure 10 to 20 above the systolic. Once hemostasis has been obtained, over the next 15 minutes, slowly decrease the femstop pressure to the patient's mean arterial pressure. If hemostasis is still achieved, reduce the femstop in 10-minute intervals, thereafter 10 to 20. So what I'm going to tell you is if you get a femstop, just refer to the policy, and it will pretty much do a good job of walking you through it. As you see there, D is radial access site for the TR band, but we'll talk a little bit about that. Alright, so now we're going to talk a little bit about TR bands and radial access. So why would you want to use radial access? Well, there's several reasons. One, there's two arteries in one area, so you have a dual blood supply. If you have a patient who has femoral arteries that are less than optimal, or say they have severe occlusive aortoiliac disease, then you can use their radial artery. Or if you have your COPD or your CHF that can't lay flat. The other thing is that a radial artery is extremely easy to compress. There is less of a chance for local nerve injury. It allows for earlier ambulation. Complications are less frequent, and patients usually prefer a radial approach. So why do we care? Well, it leads to better outcomes, faster discharge and recovery, reduced risk of complications. Patients can sit up and walk within minutes after their procedure, and there's usually increased comfort for your obese patients, patients with peripheral artery disease, and patients who have back problems. The other thing is it also improves nursing satisfaction and patient satisfaction, because it's a lot easier to manage one of the patients with a TR band than it is a femoral sheath. So, contraindications, patients who have abnormal Allen's test, patients who have abnormal pulse oximetry, patients who may require devices that are not compatible with a 7 French or smaller sheath, history of Berger's disease, severe Raynaud's, or other forms of upper extremity peripheral vascular disease. So the first thing you will do before you would send a patient to have a TR band or a radial approach would be an Allen's test. So to perform this test, you're going to occlude both the radial and the ulnar arteries, and then you're going to have them make a fist, watch their hand change color, and then you will let off the ulnar artery, and then as you can see, their blood flow should come back fairly quickly, under 8 seconds. Pulse ox should be placed on the index finger or the thumb of the arm that was used. This further allows us to look and see if the patient has good pulses. It allows for continuous assessment of the vascular integrity, and the wrist should also be kept straight. Alright, and this is what the TR band looks like. You see there's a syringe attached, or they're using a syringe in the picture on the right. And if that syringe does not come over with the patient from the cath lab, we need to call the cath lab and see about getting that syringe. It has a special end that allows you to put in and pull out air, and it is not an item we keep in stock by itself. It comes actually with the TR band in the kit. And this is just another picture. You see they're taking the radial arterial sheath out in the left, and on the right is the actual band and the syringe. Again, make sure that that syringe accompanies the patient from the cath lab. Nursing management, usually these patients are going to be, the lines are going to be pulled despite anticoagulation use. Hemostasis is usually not a problem. They can ambulate post sedation recovery. So if they're still groggy, you know, you're not going to get them up. But if they're not groggy and they're alert, oriented, and all those things, then yeah, you might get them up. Vital signs are less frequent than with femoral access, but they should include assessment of perfusion and the Allen's test. They should not have any venipuncture on the affected extremity. I was asked, well, how long for? You know, I'm going to say a week. I would tell them if they had to have labs drawn for that week, they should probably have it drawn on the other arm. No blood pressure is to be taken on the affected extremity side too. So if they had a right radial approach, then no blood pressures on the right, no venipuncture on the right. So monitoring. While the TR band is in place, if the patient has had a diagnostic only procedure, you will do site checks every 15 minutes. Vital signs will be monitored every hour times 3, probably more frequently for us because they're usually hooked up to a monitor that slaves into our charting. Balloon deflation with the TR band, it will be occurring passively over the 2 hours the TR band will be in place. The last half hour you will actively deflate it, but we'll talk about that on the next slide. If your patient has had an intervention, then you'll do site checks again every 15 minutes while it's in place, but this time you will allow the TR band to be in place for 4 hours post the removal, and you're going to check vital signs every 15 minutes times 4, then every hour times 4. Deflation, so like I said, the TR band actually passively deflates on its own, but during the last 30 minutes, you're going to take the TR band and release 3 milliliters of air every 15 minutes. And you're going to continue to assess the site, making sure hemostasis has been achieved. If bleeding reoccurs, then you're going to re-inject air at 1 milliliter at a time. So you put in a milliliter, see if that works. If it doesn't, give it a few minutes and put in another milliliter until you're going to do this process until the bleeding stops. And then repeat the deflation process in another 30 minutes. Prior to your TR band removal, make sure you have hemostasis. Cover the site again with a sterile dressing. Make sure you're assessing the site 1 hour post your TR band removal. Complications with a TR band, they're rare, but they are better tolerated. They can have pseudoaneurysms, just like they can with the femoral site. Pressure dressing will help. You applying pressure will help. You may notice local swelling, so you could treat that with ice or analgesics. And if they have re-bleeding, then elevate the hand and use local pressure, which is a nice benefit to the radial approach. It's a little hard to put somebody's groin up in the air to allow gravity to help us. Activity limitations, if they've had the TR band, you're going to limit movement of the affected extremity for 24 hours. No lifting, pushing, or pulling with that extremity greater than 5 pounds for 24 hours, and then for a week, no lifting, pushing, or pulling greater than 10 pounds. They can shower but avoid submersion of the site for a week, and they should not do any flexion or extension activities with their arm for 24 hours. Discharge instructions, they should report any symptoms or other than slight tenderness at the site. They should report any tingling of the fingers and hand that occur after 3 days. Some is expected, so if it's 1 to 2 days out, then they may just keep an eye on it. But if it's 3 days out, they may ask them to come in and have a look at them. Remove the dressing after 24 hours. They should keep the site clean and dry and covered with a Band-Aid until it's healed. No driving for 48 hours. And they should apply manual pressure if rebleeding or like a hematoma occurs. Now the patient's not going to know what a hematoma is, so if they have like a lump or a bump that suddenly starts forming, they should hold pressure at the site. Okay, so now back to our policy, the arterial sheath removal. And if you look at D here, it talks about your TR band management. RN will monitor site every 15 minutes. No blood pressure taken on the affected extremity. 2 hours for diagnostic procedure, 4 hours for interventional procedures. If the patient complains of pain, I didn't mention this before, but you can remove up to 3 milliliters of air. I'd just do 1 cc, see if that improves the pain, then do 2. If that doesn't improve it, then do 3. If bleeding reoccurs, you can inject 1 milliliter of air at a time with a syringe until the bleeding stops. And the total volume that is allowed of air in your TR band is 18 milliliters. While the TR band is on, it will slowly be deflating, like I said, passively deflating. And during the 30 minutes, the final 30 minutes, you're going to release 3 milliliters of air every 15 minutes. If it starts to rebleed, then you will put 1 milliliter of air in it till it quits bleeding, and then you will try deflation again in 30 minutes. If you haven't seen a TR band and you would like to, please just schedule some time with me and I'll let you play with the TR band. But basically it's a bracelet that has a little pillow that you fill up with air and it holds pressure on the site. So they also in this policy have care of the site, what you would do. You could use a sterile Band-Aid or equivalent dressing. I find most people like to use the Tegaderm and the BioPatch. Notify the physician, significant decrease in hematocrit or hemoglobin. Clinical changes in their cardiovascular status. And then it even goes through your abnormal findings versus what your normal findings are. I'm not going to go through all those again, but as you can see, they definitely did use evidence-based references. The other thing I want to mention that I think I forgot to mention is that according to this policy, if you have both a arterial sheath and you have a venous sheath in place, you should remove the venous sheath first, which is the way I always was taught to do it. And that's what the policy says currently. But if you look in the AACN procedure manual, it actually says to pull the arterial first, because if something should happen like profound hypotension or something like that, you will want to have that venous sheath in place to infuse some fluids rapidly. But basically, whatever you do, I would follow the AACN guidelines because that's our scope of practice, that's our standards, that's what we go by. Make sure you don't pull them at the same time. All right. Okay, and that is the end of this virtual care camp. So a quiz follows. Just write the answers down, email them, whatever you want to do. Email them, type them, write them, put them in my mailbox. Just the sooner you turn them in, the better. Thank you, and if you have any feedback, just let me know.